Welcome to a two-part series on professionalism. This is part one. I'm going to talk about laying the foundation. What is it we need to understand? The theory, the concepts, the foundational elements to be a professional. And whether you are viewing this live or on demand, you can view part one by itself, part two by itself, or I might even suggest that you do them back to back to get the best bang for the buck, as it were. These are my disclosures. I have no conflicts of interest with regard to the content of this. I will say that I've been a proud AARC member for a lot of years, probably more than the folks listening on this. And I'd encourage you, if you're not a member today, to join the AARC. My disclosures is that proceeds from this honorarium will be provided to the following charities as I speak. These change over time. But I actually ask you to think about this. As respiratory therapists, do we have the ability to provide either dollars or our time to help those in need? And as I say, food and clothes for the body, hope for the soul. Our learning objectives today are understand the foundational elements that define professionalism. Secondly, appreciate the characteristics. And I'm going to use a couple different terms there for traits and characteristics and behaviors, but appreciate the characteristics that align with professional behavior. Thirdly, is we have to do something about it, right? We want to turn that theory into practice. So the third objective is to apply the principles and characteristics of professionalism in your workplace. Now, I always start with the why, the what. What is professionalism? Back in the day, I would reach over and I would get this big, heavy book called a dictionary. It was either Webster or Merriam-Webster, and I'd page through until I found the P's and I would see professionalism. Today, that's obviously on the web. But whether you're a paper or a web person, here's the description, the definition of professionalism that first pops out to us. The conduct, aims, or qualities that characterize or mark a profession or professional person. And that's what the book says. I just want to pause in this to say, let's underline conduct, aims, qualities, characteristics. I'm going to talk about these using several lists that are available on the web or in a book perhaps. And I'm going to focus on the words, what are the traits, the characteristics, and behaviors. Now, traits and characteristics are those adjectives, as it were. He's an honest person. She's got high integrity. But are we able, as professionals, and hopefully we are, to make those adjectives into nouns and behaviors? This is what we do as a professional, having these qualities or traits or characteristics. So that'd be the goal. And I'm going to stop right here and say, there are pictures on here. We know, don't talk religion, don't talk politics. I'm not talking about in this slide. But I want to make several points. One is professionalism, leadership, servant leadership are terms that have a lot of overlap. In fact, if you've heard me talk in other venues about servant leadership and remember some of those tenets, you will identify those in this presentation and the part two. Three people, Rosa Parks, Mother Teresa, and Jimmy Carter. Now, why do I have their pictures and a name on this slide? I close my eyes and pause. I said, is there any one, or in this case, three, of people that I think about, there's a consummate professional. Forget their occupation or what they made in the headlines. And I came up with these three individuals. How did I do that? I closed my mind, and in my opinion, my experience, my knowledge, I used an innate list of characteristics that these folks aligned with. Are they the best? Are they only? Certainly not, and certainly not. But let's take this to the respiratory therapy world. I did the same exercise, in fact, last weekend. when I was preparing this presentation. And I thought, what are the titles or areas of work or care venues from RTs? And does a face and a name pop up? So here's my list. Someone who is the consummate professional in terms of professional speaking. I closed my eyes and immediately the name Patrick Dunn came up. Yes, he's a friend. Patrick's a former president of the AARC, former president of the California Society for Respiratory Care. And if you ever listen to Patrick Dunn speak, you will be in awe if you're like me. So what I do, I listen to him speak and I take notes. What did his slides look like? Did he use color? Did he use animation? What was his body language? What was his terminology? Did he pause? Did he reflect? Did he engage me? And the answer to all those in terms of Patrick Dunn is yes. And honestly, how I do it, I make a list, a pencil and piece of paper. And said, these are changes that I want to make when I'm a public speaker. And whether that's at the AARC Congress or at your department meeting, these are characteristics, behaviors, attributes, traits that I want to emulate. So what's another professional when I've closed my eyes? Researcher, scientist, Dean Hess, former editor of the AARC, a fellow, our AARC Respiratory Care Journal, a fellow in the AARC, and just numerous accolades. Why? He's a professional in the area of research. He's devoted thousands and tens of thousands of hours, actually, to becoming a better researcher and scientist. Is he the only? Absolutely not. But that, when I'm working with friends to do a research article, what is it that I learned about Dr. Hess that I could emulate? Well, what about an RT leader? When I was starting my career back in the 70s, not too many years after that, Mr. Sam Giordano was president of the AARC, and shortly after that became the executive director of the AARC. He's since retired more than a few years, but he's still involved. If you send him an email and say, Sam, I have a question about this. What is this? What did we do back in 1997? The board of directors, you'll get an immediate reply and maybe even a phone call. So what about an educator? Bill Galvin, former program director of the Gwynedd Mercy program outside of Philadelphia. When I close my eyes and think, who is the consummate professional educator? Again, half dozen names come to mind, but Bill Galvin is the one that I'll never forget. He's the first face, the first name that pops up. Why? Because every time I heard him speak, he reminded me why I'm an RT. Simple as that. What about RT director, where I spent most of my career? Rick Ford is since retired, but Rick worked for years and years and years, decades in California. He was one of the first people involved with protocols, not only writing them, but documenting the impact of protocols. He continues, though he's retired, he continues to work with me and several others with the AARC Safe and Effective Staffing Guide. He's still in the trenches, even though he's retired. So here's my ask of you. In this presentation, I'm going to provide my thoughts, information I've gleaned from the internet, books, texts, abstracts, articles, whatever they might be, and provide this information unidirectional, me to you. And that's all well and good. But if all that happens at the end of this hour is I've given you 25 slides to look at and said, this is what professionals are and do and talk and wear and sound like, and you don't make a change and I don't make a change, we're really not professionals. So I'm going to challenge you. I'm going to challenge me. Not every slide, but every other slide or every couple of slides. Is there something that you can change, that I can change, that would make us better respiratory professionals? So right now, close your eyes. Who comes to mind when you say, Who's a respiratory professional? Open your eyes and write it down. And then, in your own way, or follow my lead, what is about her that defines her as a professional? Could be my boss, could be night shift supervisor, could be the weekend agency therapist. What is about her or what is about him that instantly comes to mind to you to say, there's a professional? I give a number of lectures on leadership, and one of the ones that I did last year, I used this list, 8 characteristics of leaders. And as I re-looked at this, I said, this is one and the same. These are characteristics of leaders, and I would consider this characteristics of professionals. Knowledge, competence, confidence, integrity, respect, EI, appropriateness, conscientiousness. We could argue leaders should have those characteristics, should demonstrate those characteristics. And as professionals, regardless of our position in the hospital or home care or education, wherever it might be, we should have those. So let's just take a minute and talk about this list. Knowledge. We can't rely on what we learned in school and stop there because things change. We owe it to our patients to both maintain that knowledge and keep current. How do we keep current? Read journals, textbooks, abstracts, attending live and attending virtual presentations as you're doing here. So what about competence? What's different about competence than knowledge? Knowledge simply isn't enough. You've heard it say, well, book smart, street dumb. We could know exactly what the book tells us to do. The oxygen hemoglobin dissociation curve, I shall never forget it. The 4 factors that shift it right and left, I shall never forget it. But how do I use that at the bedside? That's why we're competency tested in school. We're competency tested in most departments on your annual comps. If you do that in your department, we've got to be competent. Now, the third one, we have to be knowledgeable. We've got to be the masters of respiratory care principles and practice. We have to be competent. But what about confidence? Being competent is not enough. We must use our knowledge and competency and perform it in a way that others see our confidence. And simply, if I'm competent, but I don't look like I know what I'm doing, I may not be accepted as a professional. I'll give you a personal example. When I was in school, we did a number of heel sticks, both on mannequins and then did them with kiddies. But I'm here to tell you that I don't think I'd want to look at a video of myself doing my first couple heel sticks on my own. I knew what to do, but did I look like I knew what I was doing? And I'll probably take the old retrospective scope back in time and say, probably didn't look like I know what I was doing. My hands were shaking, the sweat's running down my back. So does that give confidence in my abilities to that nurse, physician, or mom in the NICU? Integrity, easy. We all know what integrity means. Well, we don't. Your state licensing board, hopefully not many, but gets communicated that people are not being truthful in their practice and they get caught. If we all practiced the highest level of integrity, we would not have any legal cases against anyone in healthcare. I'm not talking about RTs at this point. I use the phrase, if you mess up, fess up. It's always better in the end to say, I made this mistake. If we practice with integrity, we'll be respected. No one will question our professionalism. What about respect? We've all heard that phrase, we can't expect it, you ought to earn it. Well, it's that simple. I see on social media in particular, we don't get any respect, or grammatically incorrectly, we don't get no respect. We get no respect. You don't get it, you got to earn it. It's that simple. It sounds hackneyed and trite, but that's it. Emotional intelligence, and this is something I started to explore a couple of decades ago. I read an article, is IQ isn't all there is. Got my attention, so I read it. Emotional intelligence. Numerous articles and books based on research have been written about that, And the finding is always the same. Emotional intelligence is more important than IQ in terms of success. And again, you can Google it. There's some really, really great studies out there that aren't difficult to read that show that if all you have is an IQ, but you don't have emotional intelligence, your success, meaning your promotions, even your income, are less. What about appropriateness? What's that mean? Well, it's simple as don't come to work looking like you slept in your scrubs. It's also communication, consistent interaction with physicians, patients, and everyone. And I'll talk a little bit about this a little later, but dress for success, or whatever that phrase is. It does make a difference. What about conscientiousness? Dedication to continuous learning and improvement. Back in the day, we did IPBB and spirometry, aerosolized N-acetylcysteine, and bland aerosol, or even blow by back in the day. But we don't do this anymore, right? Because we're conscientious in maintaining our education and competency. While those procedures were done by most every one of us back in the day, we shouldn't be doing those today unless they're clinically validated. So here's another list. And again, you Google professionalism and you'll come up with dozens of lists. I put this one together because I want to talk about each of these and give an example, and also challenge you and me to be able to amplify, to operationalize, to do each of these in our own way. So let's go through them one by one. So what is trust? My opinion, my experience, professionalism starts with, ends with trust. If you don't have the trust, it's a non-starter. We have to be trusted by patients, families, physicians, nurses, and fellow RTs. Without that, there's no step two. It's just that. So what's an example? I trust that when you get done with first rounds, that you'll call the rest of them and say, hey, I'm done, you need any help, rather than skedaddling down to the cafeteria. I trust that when you call in sick, you're actually sick. And I'm saying this as a manager, but also a fellow RT. And it's not that you just don't want to come to work. In fact, did you ever hear the phrase, I just need a mental health day? That person isn't sick. That person just can't come to work. We can't trust someone who says to us, hey, tomorrow I'm calling in sick. I'm not sick. I just need a mental health day. Can't trust them. So there's two good examples, at least in my experience, where we can take that word and say, okay, what do I do about it? Well, what about respect? It's not demanded. You got to earn it. Simple as that. And I don't know what else to say about that, but I cringe when I hear someone saying, we don't get no respect. That's not correct grammatically, but even if they say, we're not respected, well, that's on you. If you're not respected, it's because you didn't earn it. Simple as that. I like this quote by Ralph Nichols, and I never met the man, but he's the father of listening, as I heard a few years ago. And I'm going to read it. The most basic of all human needs is the need to understand and be understood. Two-way street. The best way to understand people is to listen to them. So just think about that. So Ralph Nichols, not that you'll remember this, but his moniker, his title is the father of listening. And he's been a model scholar in this way and has written numerous articles and actually books on active listening and making sure that we're not just hearing and listening. They're two very different things. I heard what you said, your lips were moving, but I didn't listen intently. Now, question is, what can you do to be a better listener? One thing, and I'm terrible at this, I'm here to tell you I'm terrible, is listen rather than just waiting for the other person to stop talking. If I had a nickel for every time I did this, I could be retired. It's difficult to do. I've seen it in the eyes of others where you've got that blank stare or they're looking at the second screen on a Zoom call or something, is actively listen, pause, and then respond. Secondly, I mentioned that second screen, turn it off. We just need to be attentive. Focus on the speaker and don't try to multitask. Multitask is doing two things at once. The only thing I'm doing now, and hopefully the only thing you're doing right now, is we're listening and talking about the principles of how to be a better listener. Just a couple weeks ago, I heard this term, continuous partial attention. Someone that I talk with regularly and I consider him a mentor said, have you heard about continuous partial attention? And I said, no, I really wasn't listening. So can you say that again? Just kidding. But this was a term coined almost 30 years ago, I think, by Linda Stone, at least back in the late 1990s. And here's the definition. I'm going to read it right off the piece of paper here. Continuous partial attention is the behavior of dividing one's attention, scanning, and optimizing opportunities in an effort to not miss anything that is going on. I'm not going to remember that definition, and good for you if you can. But what's that mean? FOMO, F-O-M-O. Ever hear it? Fear of missing out. We're darting back between two screens or a phone, or if you've got a watch that has these capabilities, I don't, or looking at an article on half listening. It absolutely is imperative that we don't fall in the trap of continuous partial attention. There's science behind it. This has been shown to lead to increased stress and decreased ability to focus and concentrate at the present moment because you're FOMO, fear of missing out. What do? Stay in a moment. Give our full attention to do it. I struggle with this on a daily basis, but hopefully I'm listening to myself as well as speaking, and I can improve my performance in this regard. So what about vision? I'm not referring to organizational vision statements to declare what they aspire to be. And I actually have a follow-up question about this, but vision and mission statements by definition are very different. Some are used interchangeably in organizations. I believe my personal experience is vision is what an organization aspires to be in the future. Mission is why we have the organization. But that's just my opinion. You can choose to use these differently or the same. But regardless, what I'm suggesting is that as a respiratory therapist, every one of us must have a vision of what we can be and what we should be. Tara and I were talking a number of times now as well about why is it that we're respiratory therapists, smart people. Take a second, give yourself a pat in the back. Why is it that some of us graduate graduate and take the MBRC exam and don't hit the cut score to become an RRT? It happens. A number of people take a second time, third time, they pass, good for them. They're not good with taking exams. But some say, I'm done. I hit the score that I need for CRT for my license. I'm done. Is that a professional? And I don't mean this on a personal level. And if someone's a CRT listening, don't take this personally. But if your vision is to be the best darn CRT you can, great, nothing wrong with that. If your vision is to have the highest credential in the association, RRT, that's your vision, and you'll work towards it. I think, and I've used this example before, close your eyes and take a time out. I think we should be able to get out of bed every morning or preparing for your shift, whatever it might be, close our eyes and have a clear vision of what we want to accomplish. What do we want to be known for? What do we want to stand for? and what others expect of us. Again, a lot of words there, but before you hop out of bed, what is it that you want to be? And then we can think about what are the steps in order to get to that point, whether it be a credential or a degree or better physical shape or more knowledgeable that can read journal articles, whatever that may be. It may be a thing of one, maybe a thing of 21. So here's what I ask you to do. Go on your website or walk down the hallway and read your hospital's mission, vision, and values. Pause. One, did you know that? Two, does that align with your department's mission, vision, and values? And three, does that align with your personal vision or mission? As an example, mission statement hospital I work for said the best care all the time, no exceptions. And I'm paraphrasing here because I can't remember it. So when I went out and I was given a big handful of treatment cards, many of which I would not get done because we didn't have enough staff to do it. I should pause for a second and say, what's the best I can do? Get my first rounds done, go back and maybe take a couple minutes to talk with the boss, my team lead, department head, manager, whomever, and say, I have 40 treatments to get done. I can't get them done unless I stack nibs. Is that consistent? And your report, direct report, might very well say, it's not, but it's the best we can do at this time. To me, that's a gut check. Now, a lot of departments, a lot of folks listen to this at this time. We have more vacancies than you can shake a stick at. At this very time, what are alternatives to that? Protocols. Protocols will give you the criteria to determine whether a patient needs a breathing treatment or not, needs that bronchodilator or not. So what you do and how you do it, does it align with your personal vision, your department vision, and your organizational vision? If it doesn't, it's gut check time. And there may be answers to improve performance, be more efficient, to eliminate waste, don't do therapies that are not clinically indicated. Or a tougher decision might be to leave and go work for some organization that does. Tough. Easy for a lecturer to say, tougher to do. I can tell you I've done it. And it doesn't necessarily go easy, but it needs to be done if there's a disconnect between you and the organization. It's not right or wrong. It's, I don't fit here. So what about self-confidence? Easy to say, easy to imagine, right? Once we've established our mission and vision, we need to have a plan to deliver our services in a competent way, but also confidence, self-confidence. I mentioned it before, if others see us as not being confident, even though we're technically competent, they might very well question our competence. Looks can be deceiving. You've heard the phrase. So what are you going to do about it? What if you ask a close friend to watch you do a procedure, listen to give a report, listen to a conversation with a physician to change an order? Do they see you as confident? Now, the reason I said close friend, you need to get honest feedback. I'm not going to talk to Bud, who gives me an A all the time. Say, look, I want you to listen to me give a report today and give me factual feedback as you see it. Am I competent? Am I confident in my delivery? Tell me what I should do differently. Chances are there's something I'm missing the boat. It could be rounds. I gave a report on this patient on a ventilator. Was I competent? Did I demonstrate my knowledge? And was I confident? Did I look like I know what I was talking about? And get that direct feedback from the people that know you well. So, close friend, associate. I'd probably say don't ask the boss to do it first couple of times around. That could be kind of queasy because if you don't look good and the boss hasn't seen you not looking good, you may not want that to be on the record. It's a good way to get better at what we're doing So when it comes time for annual comps or to sit down with your boss and talk about this, you've already run the gauntlet. You're more polished than you were before. You can also do this with another professional, a nurse or a doc or someone to say, hey, I'm going to give a report today on this ventilated patient. I'm not going to tell you what I'm going to say now, but listen to me. And simply, does it sound like I know what I'm doing? Am I practicing evidence-based respiratory care? And did I look like I knew what I was doing? So, knowledge, competency, and self-confidence. Do a gut check. Stephen Covey, I'm sure a number of listeners, in fact, probably all of us have heard this fellow over years and years and years. Kind of the godfather of leadership. I'm going to read this. You first have to ask what is right, and then ask what is possible. Always has to be in that order. He said most people, and that's a tough grade, but most people only ask what is possible and never deal with the other question. I should probably have this quote on my desk every day to look at in the morning. Can we do it? We're artists. We can do anything. We're the MacGyvers. Can we stack 4 nebs at a time? Sure. We can stack 6. Heck, we can probably do 8. You're better than me. You could probably do 10 at a time. Knock out 80 treatments in your shift. It's not the right thing to do. It's clinically ineffective. I consider it shameful practice. And thirdly, while that neb is fizzing during exhalation, it's spitting out 75% of the medication to your lungs, not the patient. So I consider it morally and ethically wrong. So can we do it? Yeah, we can do anything. Should we? No. Now, how are we going to deal with that? Let's use a practical example. You're given 40 neb treatments and 4 ventilated patients and throw in a couple high flows there for good measure. I'm doing the math here. And unless you're working at 16, that's just too much to do in a safe and effective manner in a 12-hour shift. So the question is, okay, I got to get these nebs done. The boss is going to be on my back. What do I do? Stack them? Yeah, I can stack them. Knock it out, get my points done, and life's good. But we know that's not the right thing to do clinically. And get very simple, practical examples, at least in my experience, are what we need to say to look at these definitions and say, okay, I'm doing the right thing. Yeah, I do. I can put any 2 things together, but should I? What's the patient's best interest? The AARC, actually, this is published, I'm recording this now in June of 2025. So it was last fall, the AARC Board of Directors approved a position statement on unattended care. Please Google it and take a look at it. And it says basically, it's not the right thing to do. Can we do it? Yep. Should we do it? Absolutely not. And if that's not one of the core values in your department, I think you need to look in the mirror. Bottom line, do what's right and do it all the time. Is that going to be possible 100% of the time? No. There's going to be days where there are 3 call-ins, or there's 4 code blues, or mass casualty, or a pandemic, and we're going to have to cut some corners, but should never cut corners that disallows from doing the right thing. Maybe it's what you have to do to get through the shift, but it shouldn't be the standard practice. So here's my question of you. Check your assignments tomorrow. Are they clinically indicated? Does each of those patients have an indication for that therapy? And let's just use bronchodilator therapy. Does each of those patients have a clinical indication? If not, what are you going to do? Are you going to do it just because it's in your work order? Or you do it because the boss says you got to get them done? Don't question whether they're effective. Don't question whether they're even needed. Just get them done because we need the productivity points to keep our staff. Or are you going to talk to someone, maybe at lunchtime, maybe at break, if you even get breaks anymore, and say, what do we need to do? We know that 10% of these neb treatments are not clinically indicated. Not today make the change, but let's start the discussion today to change our practice. Let's move on to communication skills. So here's an example. Rather than saying in response to a physician asking about the care plan for your patient, replace, and I heard this quote, "He don't need these treatments," unquote. 2, I completed the daily patient assessment as per our protocol and have reduced the treatment frequency from Q4 to TID and BRN. Need to take a sip of water here. Mixing my words. So I assess the patient. That demonstrates knowledge, competency, and confidence that you're talking to the physician. And as a result of that assessment grid, and I'm sure everyone has one, the patient no longer needs Q4. They now are in the category of TID and PRN. Again, I made this up as an example. What's that communicate to the physician? You know what it's talking about. And you have the patient's best interest in mind. It's not that you're lazy. I did Q4s till the cows come home, but the patient no longer needs that. I need that time. Me, the clinical therapist, need the time that, quite frankly, is wasted doing unnecessary care to do things like attend rounds, do discharge instructions, educate the patient how to use their DPI, their SMI that they've never seen before. So here's my question to you. And I ask you to put this in the chat. Does your department use patient-focused respiratory care protocols? It's a mouthful to say. Does your department use protocols? And I'm curious, and put in the chat, if you care to. Again, it's just us talking. Then the second question is, if not, what are the barriers? If protocols are the science of delivery of effective, safe and effective respiratory care, and we're not following the science, what are we doing? We're not professionals. We know better. Let's address those barriers and work on them. Enthusiasm. If you don't have today, as I say, fake it till you make it. And some days you're just going to have to do that. Bad night, the car broke down, I'm late on my mortgage payment, you get it. Fake it till you make it. The patients deserve no less. So if didn't sleep all night long, I can't let the patient know that. I may have to knock back a couple cups of coffee in order to make it through first rounds. But the patient better not see that we're anything other than enthusiastic. It just turns off others. Not just talking about the patient, certainly as foremost, but it's going to make it hard to attract students. You're, shepherding a prospective student today. They see you not being enthusiastic. They're not going to enter a respiratory therapy school. They may not enter an RT school. Or you're assigned for a new employee. They say, I'm just going through the motions. It's just a job. Maybe they check out before their probationary period ends. So here's my question to you. Do you have a negative net in your department? You might. Hopefully you don't. What's your boss doing about it? What's the department director doing about negative net? You're just a drag on the system, right? Just get your treatments done. Be quiet. Go to break. That's what we do. That's not professional. Here's the tough question. What can you do about negative net? Maybe the boss, the department manager, department director cannot address it for a myriad of reasons. Can you help? Feedback. This was a little different. I think, excuse me, it's important to give honest feedback, but we got to be respectful where we do it. Again, if we disagree with someone about a care plan, let's take it, away from the nursing station and talk about it. Don't argue in front. Give honest feedback. And I don't know about you, but I am just sick and tired of hearing people say, I just have to be honest, or I just have to be honest with you. Well, what the heck were you doing with me before you said that? Were you being dishonest? We should be honest all the time, but in the right setting. We don't want to disagree with an individual in the public eye. Patients here is disagreeing with the physician about ventilator management program. That gives no confidence to them. If we disagree, take it off stage, behind the stage, I was trying to say. So practice, what's the take home here? Practice giving professional feedback to an RT friend and ask for their honest appraisal. So do a little situation thing, a little role playing. I hate this personally, but it's a good way to do it. Practice with a friend. What about follow through? Simply, if you say you're going to do it, do it. Practical example. You served as a student preceptor last shift. No one asked you to do this, but how about emailing the faculty to say, this student was really fantastic. They really did well in their case presentation. They showed up on time. They looked like they wanted to be here. They were enthusiastic. How long does that take to type? Slow typer 2 minutes, fast typer 1 minute. Send that to the faculty. You will be doing something virtually nobody does. Trust me, this is just not the standard of care. If you do it, you're going to stand out with that program faculty who's probably going to say to your boss, hey, I got an email from Sue. Honestly, I never get this kind of feedback on students. I hear about the problems. Sue's really with it. Guess what? That could go really well in your performance review and establish your credibility as a professional. What about growing others? I've been talking about us. How can we help others? Professionals are leaders in every single position that we have. And honestly, as a staff respiratory therapist, you may have more influence on that CRT to encourage them to take the registry exam to their RRT than a department head. And again, we've heard this phrase, when you help grow others, you grow yourself. So my question to you is, how can you help others grow? Now, that's a list, and I'll go through it rather quickly, but this individual is a global leader with Boston Consulting Group, at least at the time I did the research for this. I'm going to go through these individually and give you some examples. So what about clarity? Ask these two questions. What am I trying to do? And how am I trying to do it? Could there be a better way? I read an article about idealization. I have difficulty even saying the word, but practice idealization. So what's that mean? Create future conditions or results and constantly compare what you're doing today with where you're going to end up. Do I have clarity in my professional development plan? If so, where's the plan? What is it that I'm doing today, next week, next month, next year? And it can be quite revealing, and I call it looking in the mirror. Competence, I talked about this numerous times. But developing competence means that you commit to excellence in everything you do. You do the best you can with what you got. Are we going to be perfect? Are we going to be A players? Absolutely not. But we do the best with the best we got. You set high standards for yourself. And I'm going to add this that the author didn't mention, but I think you set high standards for others as a result. So here's the ask. What one thing, if I did it to the best of my ability in an excellent manner, will have the greatest positive impact on my performance? The one thing, not 5, not 10, not 25. Pick out that one thing that could have the biggest impact on increasing your performance. What about constraints? There's some days, more hills and valleys. Between you and your goals, there will always be constraints, bottlenecks, limiting factors, choke points, time, money, got it, that set the speed for you to achieve it. We just have to be aware of it. Graduated from school, had no money. I can't begin to think about getting an advanced degree. I've got 2 years of student debts to pay off. Okay, get a plan to pay them off. Maybe even pay them off early. So here's a practical way to look at it. Ask this question at the start of every single day. What one constraint, if I eliminate it, can help me move faster toward my goal? Again, the one thing, not 5, not 25. Creativity. I don't know if you've heard, I'm just not a creative person. Okay, I'm not talking about that creativity. I'm talking about creativity where you have to have intensely desired and defined goals. You list the problems, that pebble in your shoe that's limiting you toward achieving that. And then guess what? You draft a list of questions. So how do we operationalize that? Take a piece of paper, pull up a Word document, pull up your iPad or whatever, and write as many answers to this question as you can think about it. Don't stop to think, just click them off one after the other. What one problem I have to solve will have the greatest impact on my performance? What one thing that when I solve it will jumpstart me toward my goal? That's where you're going to get into the area of creativity, not doing the same thing and over, faster or more, harder, whatever, but being creative. Now, moving on to concentration. I mentioned before, multitasking is just not the way to improve. Numerous studies have shown the deleterious effects from multitasking, and you can't do two things at once. For those people who say they do, just run away bravely. They just can't give full attention. We're not built that way. Even with AI today, you can't do two things at once and be the best. So one thing, and this is a personal peeve of mine, and I don't know if it's yours, is when I'm on a Zoom call and I see someone eyes darting back between two screens, I just stop. And I wait for that person to redirect their eyes toward me, well, toward their camera. And then I say, I saw that you need to attend to something. It was maybe an urgent email, or if you have to go to rapid response or Quibbly, just fine. But I wanted to make sure you're with the team. That goes over like a lead balloon. And I've just started to do this the last few months, and I've irked some people with it. But I say, look, I can't do two things at once. If you can, great. No one else on planet Earth has been shown to do that and have their full attention. So why don't we do this? Let's concentrate for this hour on this committee report, this write up a white paper, this abstract we're working on, or whatever it might be. Let's concentrate on this, turn everything else off. So easy to say, so very difficult to do. So here's my ask of you. What can I do if I give it my full attention is going to make a real difference? Pick one, not five, not 25. Without courage, easy to say, right? But despite what people say, a lot of us, maybe most of us, are afraid of failure. I know I am. And disagreements. But we've got to have, as professionals, the courage of our conviction, or we're not professionals. And I'm sure you can think of a lot of examples, and I'm going to challenge you to say this, but we've got to push past our fears and we have to take risks, not risks that could compromise, excuse me, safety or quality of care. That's inexcusable. But we've got to take some risks if we're going to be able to achieve the desired goal. We've got to have that crucial conversation with the boss or the physician who ordered a therapy that's not clinically indicated in the right area. Again, not in front of the patient, off stage, but to say, I'm sure you have the best thoughts in mind, best care plan for this patient with COPD when you ordered this therapy. As a respiratory therapist, could I explain an alternative therapy or frequency or modality, whatever it might be, that would achieve the goals that you have and allow us to maximize, optimize our skills? If the physician says, no, get back to work, you might want to put your resume on LinkedIn. I say it jokingly, don't certainly do that, but that's an organization that does not have a vision and a mission of providing the best care at all times. So here's my ask. What's one thing I dare to do now that's not going to fail? Kind of like the easy button or the no-brainer. Pick something that's doable. Don't pick the unachievable. I want to climb Mount Everest. I don't, but I'm not going to do that next week, but I might be able to, walk 10 blocks. So pick something that you're not going to fail at. to get dry behind the ears. So character. And I'll conclude with this. These are in no particular order, but I kind of think they are in my world. I mean, the author didn't list this way, but I think character is really the start and the end all. To develop our character, we need to be honest. We need to look in the mirror, and we need to be honest with others as well. That's a way of demonstrating integrity. And one of the phrases, many phrases I use for this to remind myself is always do the right thing. No one will ever, ever doubt your character. You may not be able to do it 100% of the time, but if you attempt to do the right thing, the right way, the right time, the right device, the right protocol, you're going to be seen as someone who's a stand-up person. And they will trust you with your abilities and your suggestions, your recommendations, far more because they know you're going to do what you say you do. Always do the right thing. I'm going to end with this definition. Dwight Moody, I'm sure many of you have read of him, but if you haven't, this is the ultimate definition that I think defines character. Who you are when no one's looking. Mr. Moody said, that person you are in the dark when nobody's looking. Are you different when no one's looking? That's not character. Do you do your best with the resources that you have consistently with high integrity and knowledge and competence and confidence to the best of your ability? That's character. And in closing, I want to thank you for investing in your career. The mere fact that you're listening to this live or might be on demand, either way, tells me that you want to invest in your career. You're not just going through the motions, not just getting your treatments done in your shift, not doing the least amount of work, not just a worker, you're a professional. And I want to thank you for investing in your career. Thank you.